This is the third part of a three-part series on neonatal EEG. It is intended for the Nicklaus Children's Hospital Clinical Neurophysiology Fellows. It will be conducted in a question and answer format. During it, I will talk to you about pathological EEG patterns that occurred in the neonatal period. The first question is, which of the following wave characteristics do not suggest encounters? A. An initial negative component higher than a positive one. B. An asymmetrical pattern. C. A frequency of 2 per minute. D. All of the above. This is a cartoonish representation of an encounters. It is being viewed from the perspective of a frontal electrode. As you can see, encounters have three waves. The first wave is negative. This is followed by a positive wave, and then a second negative wave. The peak-to-peak amplitude ranges from 50 to 150 microvolts, and the duration ranges from 500 to 750 milliseconds. It is possible to distinguish encounters from frontal sharp activity with potential epileptogenic implications. Encounters that by definition are normal has a first negative wave that is usually shorter than the following positive wave. On the other hand, the first negative wave of an abnormal biphasic frontal wave is larger than the subsequent positive wave. Encounters are synchronous. Abnormal biphasic frontal activity is usually asynchronous. Encounters are symmetrical. Abnormal frontal sharp activity is usually asymmetrical. Encounters are bilateral. Abnormal sharp frontal activity is usually unilateral. Encounters are gone by 48 weeks. Abnormal frontal sharp activity persists after 48 weeks. Encounters occurred with a frequency of 1 or less than 1 every 2 minutes. Abnormal sharp activity occurs significantly more frequent. So the answer to this question is D. Next question. Morphologically normal encounters may suggest pathology if consistently unilateral. A true, B false. Some electroencephalographers use the term encounters frontalis when morphologically normal looking encounters have normal spatial or temporal distribution within the recording and normal chronology. For these encephalographers, there is no such a thing as an abnormal encounters frontalis, and waveforms occurring in the frontal region not meeting all the parameters of normalcy that correspond to encounters frontalis are labeled abnormal frontal discharges. Others, that is, other electroencephalographers, use the term encounters frontalis for morphologically normal looking encounters even if they have abnormal spatial and temporal distributions within the recording, an abnormal chronology, or both. For these electroencephalographers, there is such a thing as an abnormal encoding frontalis. So they label an EEG abnormal on the basis of unilateral encodings in over 50% of the record, asynchronic encodings for more than 50% of the record, encodings with a frequency of more than 1 every 2 minutes, encodings being present consistently during trachea alternate, or if encodings are present beyond 48 weeks of conceptual age. Some add that they have to be more frequent in this age group than 1 every 5 minutes to be called abnormal. So the answer to this question is true. Next question. Temporal negative sharp are abnormal if A. Their duration exceeds 100 milliseconds, B. Their amplitude is less than 75 microvolts, C. Present at 40 weeks conceptual age, D. Present during quiet sleep. Several features allow us to distinguish temporal negative sharps from pathological sharp waves arising in the temporal lobe. The amplitude of temporal negative sharps is less than 75 microvolts, whereas the amplitude of pathological temporal wave is usually more than 75 microvolts. The duration of temporal negative sharps is less than 100 milliseconds, whereas the duration of pathological temporal waves is usually more than 100 milliseconds. Temporal negative sharps are monophasic or biphasic, whereas pathological temporal sharps waves are most often polyphasic. Temporal negative sharps are usually bilateral, whereas temporal waves that are pathological are usually unilateral. Temporal negative sharps occur during quiet sleep, whereas pathological temporal sharp activity tends to be more prominent during wakefulness. Temporary negative sharps occur with an interval longer than 1 minute, whereas pathological temporal sharp waves occurred with a frequency of more than 1 per minute. So the answer to this question is A. The duration of burst during TA are the same in infants born pre or full term at the same conceptual age. A true, B false. There are subtle differences between an EEG of a 41-week neonate if the patient was born at 40 weeks or was born at 28 weeks. In neonates born at 28 weeks with a legal age of 13 weeks, periods of sustained arousal are shorter, sleep stages are more variable, duration of quiet sleep is longer, duration of active sleep is longer, duration of burst in trachea alternate is longer, concordance of sleep indicators is good for those babies born full term, that is at 40 weeks, when the EEG is taken 1 week at 1 week of age, where the concordance is poor on babies born at 28 weeks, when the EEG is performed at 13 weeks. Eye movements are more prominent in those that were born at 40 weeks than those that were born at 28 weeks. Chin movement, that is clonic chin EMG, is more likely to be absent in those born at a gestational age of 40 weeks than when they are born at a gestational age of 28 weeks. They tend to be present more in the prematurely born neonate. Heart rate tend to be slower in babies born full term and faster in babies born preterm. Respiratory rate is lower in babies born full term and higher in babies born preterm. But overall, it is important to remember that these changes are subtle and they are not considered pathological. Therefore, there's really no significant difference in the EEG of a 41 conceptual age neonate, whether the baby was born at a gestational age of 40 weeks or 28 weeks. So the answer to this question is false. Next question. Which of the following is not a feature of interictal epileptiform discharges? A. Crossing the baseline after the first component. B. Rise time faster than fall time. C. Pre-spike background disruption. D. None of the above. This is a cartoonish idealization of an interictal epileptiform wave. Interictal epileptiform activity has a duration between 20 to 70 milliseconds, in which case is called a spike, or 70 to 200 milliseconds, in which case is called a sharp wave. Current thinking does not give different meaning to these two types of electrical activity. Interictal epileptiform activity have a faster rise time, represented in yellow, and a slower drop time, represented in blue in this frame. They cross the previously established baseline, therefore they are biphasic or triphasics. They are followed by a wave slower than those presented before the spike or sharp wave, which may be in the same direction as shown here or have an opposite polarity. They are preceded by a change in the background rhythm and followed by a background disruption. The background disruption goes beyond the single slow wave that appeared after the spike. They can be mapped to a logical field. They are usually negative except in infants and neonates. They arise most frequently from the anterior and mid-temporal regions or at the vertex. In these regions, the probability of a seizure when a spike occurs in one of these regions is over 85%. If, on the other hand, the activity is present in the central, frontal, or occipital region, the likelihood of it being linked to seizure is less than 75%. For Peter Gore, a famous neurophysiologist, he believed that parameters 1 and 3 are most reliable in distinguishing epileptiform activity from non-epileptiform activity, and that at the time of making a decision, they should weigh more in the process than any other parameter. In this frame, I am representing an ictal epileptiform wave in magenta and a benign sharp wave in yellow, so you can see the overall difference between them. So the answer to this question is D. Next question. Which of the following is not true regarding physiologic negative sharp waves? A. Greatest abundance in the mid-temporal, central, and centrotemporal regions. B. Rare in frontal, midline vertex, and occipital regions. C. Mostly single, solitary transients. D. Never in trains or runs. According to some electroencephalographers, benign sharp waves are likely to be 100 to 200 milliseconds, likely to be symmetrical, arising from a normal background, usually single, but at times may occur in brief trains or runs. These same authors think that they are more likely to be found in the mid-temporal, centrotemporal, and central regions, and less likely to be found in the frontal, vertex, or occipital regions. So the answer to this question is D. Next question. Negative sharp waves that occur with a frequency as high as dash per hour for preterm and dash per hour for term infants are normal. A. 7,17, B. 11,13, C. 12,8, D. 6,15. The numbers to remember are 11 and 13. So the answer to this question is B. Next question. Which of the following is not true regarding brief rhythmic discharges? A. Lasts less than 10 seconds. B. Has similar mortality and morbidity than seizures. C. Have also been called birds or birds. D. Usually are present in otherwise normal EEGs. The definition of a brief rhythmic discharge was established in 2013. Brief rhythmic discharges are evolving rhythmic patterns of electrical activity that share many characteristics with seizures, but are very brief, with a duration of less than 10 seconds, and they have an uncertain significance regarding whether they are ictal or non-ictal, but they do convey very poor prognosis. Brief rhythmic discharges are usually seen in conjunction with an abnormal EEG background. Other epileptic-like patterns resemble this activity. I will address it in the next few frames. Epileptic-like patterns in conjunction with clinical manifestation is often given a name and has prognostic implications. Rhythmic activity with characteristic of ictal activity lasting 10 seconds or more, in conjunction with clinical manifestations of the type usually seen in convulsions and neonatal seizures are called electroclinical seizures. And in general, in the absence of immediately treatable conditions, have a poor prognosis. An activity lasting the same duration, not associated with clinical manifestations, is called an electrical seizure or an electroencephalographic seizure. And they also carry a poor prognosis. An activity with similar characteristics but lasting less than 10 seconds, in conjunction with clinical manifestation of the type usually seen with proven seizure, is referred to as an electroclinical seizure. And it has a poor prognosis but better than those prolonged electroclinical seizures. Morphologically similar patterns of less than 10 seconds, not associated with clinical manifestations, are called brief rhythmic discharges, and they also have a relatively poor prognosis. So the answer to this question is D. Burst suppression is an invariable pattern. A true, B false. During the neonatal period, there are 4 discontinuous patterns that are frequently seen. They differ according to the conceptual age, reactivity, interburst interval amplitude, and burst activity. Tracé discontinue is seen in babies less than 36 weeks, although some authors say that they can be found or can be present up to 40 weeks. Most agree that it is a reactive pattern, but some do not. The interburst amplitude is between 2 and 25 microvolts, and the activity during the burst is age appropriate. Tracé alternate is usually present between 36 and 44 weeks. Is reactive. The interburst interval amplitude is more than 25 microvolts. Again, some do not agree with this number. The activity during the burst is appropriate for age. The next pattern is excessive discontinuity. Excessive discontinuity is a pathological pattern that implies that the interburst interval is longer than it should be. As such, it can occur at any age. Reactivity is variable at time present, at time not present. Interburst interval amplitude is also variable, and the burst, that is the activity within the burst, may or may not be age appropriate. Burst suppression, the last of the 4 patterns I will mention to you at this junction, can occur at any age in the neonatal period. Most believe that no reactivity can be present during it. Most also believe that the interburst interval amplitude should be less than 2 microvolts and to have a constant duration. The bursts are characterized by spike and sharp waves. Burst suppression activity has a very poor prognosis. So the answer to this question is true. Next question. Burst suppression has been defined as an invariant pathological pattern characterized by bursts separated by prolonged low voltage activity between the bursts. A true, B false. This definition has been put forward many times, and as you can see, is characterized by invariability, burst of abnormal activity, and being separated, according to some, by prolonged low voltage activity between the bursts. But not all agree with this definition. Some will call it burst suppression pattern even if the interburst interval amplitude is higher than 5 microvolt, as long as it is significantly lower than the burst and as long as the duration of the interburst activity is rather constant. So the answer to this question is true, but not all agree. Next question. Burst suppression can occur independently in each hemisphere. A true, B false. This is an example of burst suppression occurring independently in each hemisphere. This pattern may occur in patients with migratory errors and agenesis of the corpus callosum, but at times it occurs in patients with metabolic encephalopathy. So the answer to this question is true. Next question. Please look at this epoch and choose best answer. A. Right temporal hemorrhage. B. Non-ketotic hyperglycinemia. C. Herpetic encephalitis. D. pyridoxine-dependent epilepsy. Notice in this epoch the amplitude. Most of the activity in the right temporal region is less than 10 microvolts. It is certainly lower than the activity in the left temporal region, but it is also lower than the activity in the right central region. And as you recall, continuous activity below 25 microvolt is considered low in neonates, and continuous activity less than 10 microvolt is usually abnormal, especially in full-term neonates. So, the diagnosis that was encountered in this patient was a right temporal lobe hemorrhage. And the answer to this question is A. Which of the following findings puts in question the pathological significance of an asymmetry over 50%? A. Preservation of normal background activity. B. Restricted presence to one behavioral state. C. Presence limited to one montage. D. All of the above. Findings that put in question the pathological significance of an asymmetry, even if it is more than 50%, include preservation of normal background activity, restricted presence to one behavioral state, presence limited to one montage. So the answer to this question is D, all of the above. Please look at this pattern and choose most appropriate answer. A, right temporal hemorrhage. B, non-ketotic hyperglycinemia. C, herpetic encephalitis. D, pyridoxine-dependent epilepsy. When considering how to answer a question, always read the answers presented to you. Focal epileptiform discharges is the classic EEG presentation of herpes encephalitis. Other conditions, such as hypocalcemia, hypoglycemia, and many others, can produce similar findings, but they are readily diagnosed by blood test. And in addition, they were not an option in this question. So the answer to this question is C. Next question. Please look at this epoch and choose best possible answer. A, maple syrup urine disease. B, non-ketotic hyperglycinemia. C, drug intoxication. D, pyridoxine-dependent epilepsy. Continuous spindles, when associated with diencephalic and brainstem edema, is almost pathognomonic of maple syrup urine disease. So the answer to this question is A. Please look at this epoch and choose best possible answer. A, right temporal hemorrhage. B, non-ketotic hyperglycinemia. C, herpetic encephalitis. D, pyridoxine-dependent epilepsy. This pattern consists of high voltage slow wave resembling a spike and wave, and is very unusual for neonates. When you see it, think of pyridoxine-related epilepsy. But the only patient I've seen with pyridoxine-dependent epilepsy had the pattern that you see here, which is consistent with burst suppression. So its absence should not be taken to imply that a pyridoxine-dependent epilepsy is not present. So the answer to this question is D. Next question. Please look at this frame and choose best possible answer. A, right temporal hemorrhage. B, non-ketotic hyperglycinemia. C, herpetic encephalitis. D, pyridoxine-dependent epilepsy. This pattern is probably best classified as a discontinuous pattern. It is often found in patients with non-ketotic hyperglycemia, as it is often associated with this condition, but patients with non-ketotic hyperglycemia very often present with frank burst suppression pattern. So the answer to this question is B. Next question. Please take a look at this pattern and choose the best possible answer. A, periventricular leukomalacia. B, non-ketotic hyperglycinemia. C, maple syrup urine disease. D, pyridoxine-dependent epilepsy. Positive discharges in the central region are usually pathological. They are often associated to periventricular leukomalacia regardless of their frequency. Whereas when these discharges are present in the temporal region, frequency becomes a criteria for indicating pathology. In preterm, a frequency of 3 per hour is considered abnormal, whereas in term, a frequency of 1.5 per hour is considered abnormal. The presence of this type of activity indicates white matter disease. Physiologic positive waves can occur in the temporal region, but they must be rather infrequent, more so in full terms than in preterms. Physiologic negative sharp waves, which are characterized by being single, rarely brief trains or runs of 100 to 200 milliseconds, symmetrical sharp waves randomly spread over the mid-temporal, central, and centrotemporal region, are at times seen in the neonatal period. These physiologic negative sharp waves are rarely seen over the frontal, midlight vertex, and occipital region. The background associated with physiologic negative sharp waves is normal. Pathologic negative sharp waves, which are characterized by being single, but more likely occurring in brief trains or runs of waves that are less than 100 milliseconds and highly localized to a given region, can also be seen in this age group. They are associated with abnormal EEG background. So remember that positive discharges in the neonatal period, when occurring in the central region, are often associated with periventricular leukomalacia. So the answer to this question is A. Next question. Please look at this epoch and choose best answer. A. Leukomalacia. B. Seizure. C. Benign familial neonatal seizures. D. pyridoxine-dependent epilepsy. Benign familial neonatal seizures have been reported to occur in association with the pattern that you're seeing in this frame. This pattern is called theta Ponto alternate. This pattern is characterized by a wave in the middle of a complex of wave that sticks out because of its bigger amplitude as a sore finger. I have enlarged them in this frame to make it more obvious. So the answer to this question is C. Next question. An abnormal EEG at 3 weeks of age, followed by a normal EEG at 3 months, indicates good prognosis. A true, B false. Neonatal EEG is more reliable to prognosticate than an EEG done at 3 months of age. I like to do an EEG for prognostic purposes after the first week of birth. I think that it is most helpful when it is done between 1 and 3 weeks of postnatal life. Please take a moment to read the comments in this page. They are very wise. So the answer to this question is B. Next question. In neonates, changes in amplitude indicate chronic brain injury, whereas changes in waveform indicate acute brain injury. A true, B false. Changes that indicate acute pathology are those that involve continuity, frequency, and amplitude. Changes that indicate distant pathology are changes in maturation and waveform. So the answer to this question is false. Next question. Rhythmic implies a pattern in which waves have a relatively uniform morphology and duration, and there is a quantifiable regular interval in consecutive waveforms. A true, B false. Periodic implies a pattern in which waves have a relatively uniform morphology and duration. There is a quantifiable regular interval between consecutive waveforms. Rhythmic implies a pattern in which waves have a relatively uniform morphology and duration, without interval between consecutive waveforms. The duration of each consecutive wave in a pair cannot vary by more than 50%. Status epilepticus is defined by some as the sum duration of seizures totaling more than 50% of an hour epoch. This means that a seizure or a continuation of seizures that last for more than 30 minutes in 1 hour. So the answer to this question is false. Please take a look at this pattern and choose best possible answer. A, rhythmic pattern. B, artifact. C, seizures. D, status epilepticus. Always look at the video. Once you look at the video, the answer to this question is obvious. So the answer to this question is B. Thank you very much for your attention.